Well, really, our plan today was go over some things I normally do exercise wise and that type of thing. But did you have any questions or anything before I get rolling on some thoughts?
I've got a question, but I can't remember what it was. So I'll come back to you. No, I've had a brief look. Where did I get up to? Your last video, I haven't quite finished it. The exercises, so I'm interested to hear what you have to say on things. So I'm more than happy for you to just go through what you've got today. That would be really
Yeah,
helpful.
yeah. I'll just kind of break down. So here is the. I'll kind of break down in a organized way as best I can how I approach exercise therapy. But the first thing that I would keep in mind is when you kind of enter this realm is that these exercises you prescribe should not reproduce symptoms. Okay, so just like a total opposite switch to vestibular therapy where you're trying to stimulate symptoms. Now, theoretically, it is a fatigable condition, meaning like when our evaluation component, we had the latency period and the duration of symptoms and fatigability. So that means like if you're going to get somebody to look up and they get symptoms, if you get them to look up 5, 10 times, then maybe it dampens down. But I would say from a really organized way of doing that, I would rather you get, okay, that brings on symptoms. Where do you feel it hinge? And then when we start to prescribe exercises, you should be able to get it so it doesn't bring it on for several reasons. It's a otoneurological symptom that your body's like, hey, I'm pissed off. Okay, I'm giving you a signal, and you keep making me exercise, and two, that precipitates a lot more fear of movement and exercise when you know something's going to come on like that, right? So that's first and foremost what I would say. All right. Second of all, my big principles with that is that ultimately we want to aim for symmetry. Okay. Think of that as what we did with the Atlas mobility last time. So we're just aiming for symmetry. And again, we may not be able to get 100%, but that is ultimately like a goal that I'm looking for. More than likely, people's symptoms are going to go down tremendously if they have done absolutely nothing and you intervene with some of your manual therapy and some of this. It typically will improve. I'm talking about the real tough cases, the ones that these people may live an active lifestyle. They've done physical therapy, they've done vestibular therapy, they've done chiropractic work, and they're coming to you and say, well, what else can you offer for me? So I always keep that aiming high. That all right, that is an internal goal that I'll be looking for. Okay, and so when we talk about symmetry, we have what we did last time, which is the Atlas work. Okay, and we discussed that. From a muscle standpoint, the first and foremost way I look at symmetry is just front to back, okay? And have you heard of like the whole concept of deep cervical neck training? Have you guys heard of that? Okay. Been around since probably early 90s. It's been around for a while. Okay. Nothing crazy new on it. But here's the component that I bring apart is during my evaluation, sometimes there are different ways that we can test the deep cervical flexors if this is something that you want to test, right? You can obviously use the blood pressure cuff method, which is Joel's work, right? And kind of see where you are. That has been demonstrated with reliability and validity with esophageal EMG, blah, blah, blah. It goes down. Quite frankly, I don't use that. Haven't done it we don't have one. And I haven't done that in a long, long time. And it's nothing wrong with it, but it can be a good toolbox for you if you want. But I go with a little bit of a quicker route because you have time like me to work with these people, but Instead of like starting at 22 millimeters of mercury and getting someone to hold it 10 seconds, see if they're compensating, see blah, 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 and working way up to ultimately get the gold standard of like 28 millimeters of mercury, 10 times 10 seconds. I do two things. One thing I do is quite simply, how do people work in a sitting position? Because that's in a loaded position. And I call a neck flexor, I call this as the poor man's test. And I will say, hey, put your hand here, push your head back as if you're going to push back, but you hold your muscles here and see what works. Okay? And you can test this on yourself because I know you have a little bit on that right side. Ultimately, when we do this, this could be an exercise. This is an isometric. We want somebody to feel it, and you can tell me where you feel it, Sarah. We want somebody to feel it right here. Where do you feel it? Yeah.
Front and back on the left.
Okay.
On the right.
Okay. Yeah. And so remember that right side's your tight side. So a lot of times you say, well, tightness may be weakness. In today's terms, they'll say, if you're tight, you're weak. And that's that's like the 2010 physio come out of school. That's what we do. Let's strengthen everything hard. Okay. Which is good. It's probably better than stretching everything. But so you're like, well, that could be a great exercise for someone. It's an isometric, okay? It's engaging. But even for you, it's like, well, we're getting some sort of firing on the left atlas for some reason. And we're also getting, I think you might have pointed a little bit more SCM than you did even here. Yeah. So just think. So I use Adam's apple. Now these guys we want the longest coli, longest capitis kicking, and it should feel almost like next to your vertebrae for the most part. And that's where it does. It connects to the anterior border of the vertebrae. Just go to Google and search longest coli, longest capitis, and see exactly where they are, because that is exactly what we're trying to ultimately engage for some of these individuals. And so a lot of people will come to me and they'll be doing kind of like you're doing here. They've found somebody on YouTube or Instagram and they're doing all this stuff and it's not moving the needle, right? Because ultimately we want it to be able to move through range. But if we can't get it to move through an isometric, how good is it going to be to control your head when you go into extension or to help obviously improve lordosis of the neck? And so, for you, let's figure out. So we'll come back to my other test, but let's do this one because it's in loaded. And I don't know about you, but 99 out of 100 people are going to show somebody isometric like this, right? They're like, push here, 10 seconds. If you read any physio research, they got their eyes blocked out and they're like this. I read every day, all day, and I'm like, like we can make it so much better, but that's research and it's a very standardized protocol. Very simple, but for you, let's figure out so based off of what we found, you know how last time we were looking at that retraction and we were looking at how well your atlas, I think we were angled down a little bit. So
yeah, we did. We went down, didn't we?
Yeah, so now maybe have your head in that position, Sarah, and now push on the front. And so now we're at about 30 degrees or so flexion. See if you get anything different.
Still similar, but not as intense at the back.
Yeah. Okay. So we want less in the back. So that's the first part of exercise therapy that I ultimately test. Okay, so this could be like a day one test. You know, you're thinking of it and you're like, well, what kind of muscle imbalances am I finding besides tightness? Right? And so, for instance, for you, I would say, well, I would not prescribe that exercise with horizontal gaze. We may prescribe it with your head down, in order to get the right muscles. Now, you weren't symptomatic in the back, but what if the motor neurons on the suboccipitals were so pissed off at you that just a little bit of that engagement on the back side turned that into dizziness.
I missed all of that. I got cut out.
Oh, I thought something changed. Oh, what I was saying is I wouldn't prescribe that exercise based off of your tests in horizontal gaze here. I would initially say, well, we need to maybe prescribe it downward because what we're doing, we're engaging the right muscles, right? Okay. So that may be, this is kind of testing, starting the treatment, just kind of getting you understand of like, how can we take something very simple and because they may have come to you and say, hey, this stuff didn't work before, right? And then you're like, well, maybe I need to not do anything, but maybe it was just a simple connection thing that we need to look at. So just something to think about. Or they may say, hey, when I do this, it brings on symptoms. Well, it might be that we need to tilt the head in order to not engage the suboccipitals, just like yourself, in order to get the right muscles to work, which then theoretically shouldn't send any negative input to the vestibular nucleus, which would, in the really pissed off cases which come to us, that could be enough of a signal to make somebody, and they may not feel it then, but they may feel it when they stop. They may be like, whoa, like now I feel dizzy. And so that is another little key component is when we do the exercise, like just like you and me might go to the gym, when you're done with your set of bicep curls, you'll be like, whew, that's tight. The muscle got tight, right? And that's exactly what we're trying to prescribe here. We want it to not bring on symptoms during it, afterwards, and now that's obviously some things to tell the patient, but me and you are going to say, all right, well, how can I prescribe it to make it even better? And so this just correlates along with the other lectures that we've talked about of like, how is the orientation of the neck? How can we take what somebody has coming in and really improve the pathology of going on? Because these are the ones that need us the most. It's not those easy BPV cases, right? But so just something to think about. And have you ever ran into anyone who's done any like neck exercises that feel worse?
Yes.
Yeah.
Yeah.
And my whole philosophy is that they were probably feeling worse because of it wasn't the right exercise. And then I break it down to like, it's probably not working where it should. And then that's just the body's reaction to giving you a signal, just like a signal there. So I would just kind of keep that in mind, that would be maybe not something that we obviously have to accomplish day one, but it could give you a starting point for exercise prescription, right? Okay. Because what we're going to normally find with this population is when they do it, they're probably going to feel it in the suboccipitals, in the exact opposite spot. So, and you may say, well, it's because they're tight. Well, yeah. And you say, well, I need to do reciprocal inhibition, right? Reciprocal inhibition is where you work one muscle to relax the other one. But if you're trying to work the bicep and you're feeling the tricep, how is it relaxing the tricep? it's so you could use these concepts with a lot of components. So that's going to be a major thing that we're probably going to find in 90% of or more. And this could even go to some of your PPV people that we talked about last time of like, hey, could this be some decrease of recurrence? And it could be almost a simple test, just like the hinge is my simple test. So I would say that would be the poor man's version or poor person's version of sort of examining that. That could be like a day one, because we ultimately want it, the longest coli, longest capitis are going to be attaching right to the vertebrae, right? Because when they studied these people in the research back in the early 2000s, it was on 18 to 20-year-old asymptomatics. And that's why we were able to do the deep cervical flexor test, strength test, and it had the EMG I don't know who would sign up for this test, but they basically put a esophageal and they go and they attach it to those muscles and say, hey, what? And that's how she validated the cranial cervical flexion test. That's how she validated it. I have another poor man's version of doing it, and I have this, I think, in the lecture, and it's in the good videos. It's the deep cervical flexor endurance test. And so this is the one where I get somebody to lay supine, tuck their chin, lift their head off, 2-finger breaths, and I write it. I talk about a lot in there, and it's the same concept. There are 4 characteristics that you should be looking for a positive test. 1 is, hey, make sure that they can do it. 2, does the cranial cervical component stay intact? Meaning, do they come up like this? How much engagement is in the SCM? And if you're putting your hands under the head, are they, because you don't want them to lift up way high. Like, so there are 4 components. You can look back at it. My 5th component is, where do we feel it? All right. And quite frankly, that's what I do 99% of the time. I'm going to say, all right, we're going to hold this for 20 seconds, which women should be able to hold for 20, men should be able to hold for 25. But then you could say it could be 40 seconds. The research is all over the place based off of gender, based off of ethnicity. It's between 20 and 40 seconds. Okay. But usually 20 and 25 is kind of the standard.
Yeah.
So I'll hit a timer and I'll say, hey, lay down, lift your head up. I'm going to time it. And I'll tell the patient, hey, tell me 2 things, like 0 to 10, how challenging is this? If 0 is like, this is super easy, 10 being, holy smokes, if you get me to do it again, I'm going to vomit kind of thing, right? It's like intensity. And then I just get the other thing, hey, just tell me what muscles are working after you're done doing it. And I don't tell them where I want it. I'm just like, you tell me, because that's what their brain is interpreting these afferent signals. And so it's the same thing. 99% of the time, we're going to feel it posteriorly. And in this population, a certain percentage of people are going to feel it, maybe not with the contraction, but with the release. And that's ultimately something that would be a goal to achieve, right? You could then think of how to prescribe maybe a higher load versus isometric by just putting some pillows under their head. So if you found that 30 degrees here or so, they felt it, then instead of them starting flat on the table in a straight supine position, we may need to put 2 or 3 pillows under them to get them to engage, if that is an exercise you would want to prescribe at home. Because we just want that to work here. It's my first C, that I have 5 C's for rehab, and one is connectivity. So just like a GPS is going to take you right to your office and not to the neighbor's office, we try to get real specific. So if we want to build it up, we hit connectivity first. And so that's my little 2 cents on when you do deep cervical flexors.
So it's working on. So I guess that's why you do that one rather than retraction, because I guess retraction is pulling it back into extension, right? Like rather than doing.
Yes. Retraction and deeps, and because they yes, good question. Let me put that in here. So you have like retraction, and then you have like chin tucks. People are like, oh yeah, I'm doing chin tucks. I had a lady today, like. So I'm like, well, tell me what you're doing. Like, so retraction is theoretically opening the OA and extending this way, right? And you could put over pressure of it through the maxilla. Chin tucks is, or you could have chin nods, is more of OA flexion. That's literally, not that one. That's literally cranial cervical flexion. Okay. And that's what people normally do when you do like chin tucks supine, when you're laying supine. Because the cue is not the push back into the pillow or towel or table. And I have in the book, if you look at that chapter, I give a lot of cues, try to gaze down towards your chest as you do it. Hey, there's a lot of cues that could help. So, yes, both of these can be good exercise. And both of them can be used interchangeably. Technically, you can do retraction, you can do chin tucks. It's just, if you want to get into the nitty gritty, these would be what I would be aiming for, and then we work backwards from it. So if we say, hey, this is what we want to get to work in a loaded position where I hold my head up all day long, we know that it's not gauging there. Well, let's work backwards a little bit. Maybe we lie down. Maybe we start with some chin tucks. Maybe we start with our manual. And then maybe by 6 weeks or 8 weeks of therapy, I want this thing to be working in a loaded position, because that is the way we are 16 hours a day, right? And so hopefully that kind of makes sense. That's a goal of mine versus if they can hold it 20 seconds without the SCM compensating. That's a good goal. I don't have to do insurance stuff now, but I just look at it big picture. And this is what I do with myself that I created over years ago. And it's not everything. I would say I think we'll be a little short-sighted if we just did this. That's why I'm going to teach you other stuff. Yeah. But it's definitely a good buy-in too, Sarah, I think, for your patients to be able to oh, well, shit, she's trying to get me to see and I'm feeling the wrong place. This might be something she can help me with, right? Because they're yeah, I've been doing this. My physio told me to do this, 5 years ago, right? And then it's just throwing another level of expertise for them to be well, you know what? Maybe this is where I need to be. Because they're telling me exactly. Sometimes just those little details might make a difference. So, any questions on that part?
No, that makes sense and gives little light bulb moment.
Yeah.
I definitely do a lot of retraction with people and thinking that I'm doing the right thing, but actually, and I've looked at that in the literature and seen the difference, and I'm oh, yeah, so that's good.
No, that's, and you're not doing anything wrong. I'm just trying to take it to another level. I mean, some people have been doing, if you watch me do an epley versus you'd be oh, Harrison, you don't have that extension on there that good. You may bomb me, and then the person gets better, and I'm Microsoft mic drop on you. But that's the same thing here. I'm just trying to say, if you're gosh, why is this person not getting better? Is it the inner ears cleared? I'm doing the manual therapy on the neck, and they're doing these exercises they say they're doing. We got to either look into the diet, look into stress, anxiety, look into all that. But this could be where I would feel more confident on how is their exercise prescription. So, I mean, even I had a lady come in today. It wasn't for dizziness. She went on a community page and found me for neck pain. And she's basically having radiculopathy. But she's been going to a physio, doing suboccipital release. She said it does great. That person just left. The new person, she said whatever she was doing was making her worse. So she's back on the community board trying to find somebody to help her so she doesn't have to have a fusion again. And anyway, I get her to look up, and she is right here, and it feels where it should about C5, but it's sharp pain. She doesn't like it, and she's got all these exercises and stuff she's doing, and I'm well, ultimately we need to say, what is the purpose of these exercises? Are we just giving it to like we would a modality? Let's put some heat on you. Let's put some cream on you. Or can we use these exercises to ultimately improve lordosis? I call this re-lordosis. We have de-lordosis through life. It's declining or demoralizing. We're getting more flatter spines. We don't have the curvature. What if our big picture can be how, and that's what we talked about, getting that C5 to move, right? So how can our exercise prescription help get that. Now, again, we're talking months, 8 to 12 months of us, and it can change. There's some research. It's more in the chiropractic research, to be honest, but physios don't study that because we can't do x-rays, right? So we don't care about that. We care about outcome scores and stuff, which is perfect. But if we want to think like, how can I really improve that for maybe more like substantial exercises? So when somebody's going to the gym, 10% of their exercises may be something to really focus to keep their neck going the way we want it to go. I call it an 80-20 rule, a 90-10 rule, depends on your age and depends on your condition. Like, I want you to do 80%. I want you to go work out, do bench, do machines, but I would like for you to work on a couple of these things if it's, if they're in like a maintenance stage. So anyway, what I'm getting to is that for her, like, she was saying she's doing some of these exercises and stuff, and she just feels like when she stopped getting the manual therapy, her body just started to decline. And that's great because she's coming to me and I'm going to do it and she'll get back up. But I ultimately want people to be able to help themselves for the long run. And then so if we can get them to get some of these goals that we want, then they should be able to manage neck symptoms for the most part through life, right? I love somebody to work on my neck, work it, everything we've done. It feels great. But so deep cervical flexor has the ability to ultimately get that lordosis. We know when you don't have the lordosis, that's when it doesn't fire for the most part. So then we kind of have to put you in a different position. And that's basically, instead of the bicep working completely from here to here, when I put your head short this way, all we're doing is shortening it. So then that muscle is working, but in a shortened position. But we know the longest capitis run deep right here. And what do they really need to do is control, when you look up, they're eccentric control of the neck too. So it can't just work when we're all balled up, right? We ultimately need it to get to work. And that's why we have extension as our main primary issue that's going on. And so that's one of the components of exercise therapy that we strategize with. So, okay. And so anyway, work backwards from there. You feel free to do some exercises, everything that, chin tucks, but just think of the difference of the angles. Could make it a big difference. All right. I want to go to the back now. Do you have I'll go grab one.
A towel?
No, a TheraBand. Do you guys use TheraBand? Yeah, grab one of those. I'm going to grab one. I meant to do it earlier. Cool. So, probably a little bit more of a modern, but probably about 10 or 12 years old now, we really started looking into, hey, we've studied the deep cervical flexors. We know that they're impaired with every neck condition, including dizziness. Let's start to study the extensors, right? And so that led to some of the deep cervical extensor research, and of course that I'm drawing a blank on the guy right now, but that was all his models and basically studying whiplash and finding fatty infiltration into these guys, which fatty infiltration basically means it's not working, maybe from denervation from the local segment or either disuse, from pain and not using it. So from a physio testing standpoint, we could do the old school test that you lay prone on the table with your head hanging off and pulling the chin back. Usually they'll do like 1 kilogram weight. That's research, and you hold it for like 2 minutes. I don't do any of that. that's more research. But what's the name of that? Do you know what the name of that test is? Shoot. I don't have my book out right here, but anyway, it's in the book. If you want like research, it's in the book. I do kind of the poor man's version, but this is both because it can be treatment and it can be testing. Because this is all we want. We want something that they can have treatment with. So I use the good old TheraBand, and so this is how you can do retraction, but with resistance to see what the muscles do. So I put it kind of just a little bit above my ear or over my ear, depends on how much curvature of your occiput. I straighten my elbows. There you go. All right. And then I just pull, once you kind of get it going, you just want, I'm going to step closer so you can see me. All we're looking here is just protraction, retraction, and you're keeping your eyes in a horizontal plane, if that makes sense. Mm-hmm. Keep going, see what kicks in for you. So you're gonna try to push with your arms, but think about more, like a big goal would be more control of the head. And that's fine. Do your arms if you need to, but there you go. And so just kind of work it, see what muscles work.
My right side does not work at all. There's nothing.
So that was the same as your deep cervical flexor, right? Because it was your left side engaging.
I'm getting the left side. Left deep cervical flexors working. Right and here. That's where I can feel it the most, and then a little bit up the back. This right side feels like there's nothing going on. Like it literally feels.
Well, so that's part of the symmetry work. We're talking front back, and then it's side to side. We can't get too much side to side here. It's more noticeable there. So that would be where, Sarah, that's very common, and I think that's where you work to figure out yourself, and you're going to help a lot of people that have that same trouble. My strategy would be you may have to do the same thing. You may have to have a different angle, or you may need somebody to get in there and do some of the things that we've done and then your goal would be to get it to work.
It's interesting. I'm not sure what did it, but I went temper bowling and did gardening on Saturday, and I woke up on Monday with such a stiff sore neck. And obviously I'm right-handed, so I was bowling on the right side, and so I've been doing like trying to get work in there. It's come free. I did it myself, but yeah.
Oh, good. Yeah. Well, the more I design a lot of these things because I started having stuff as I hit age 30, and I'm like, I treat this stuff. I need to figure it out even more than, so. But I think what you're telling me is extremely, extremely common for what you're going to find with these individuals. They're probably just got a lot, for some reason, their vestibular system is just more angry from X, Y, and Z reason, and that's why they may be seeking you out. And again, it could be that's just basically asymmetry that we're looking for, and because you're tight on that right side, so you're saying, oh, I need to strengthen it if you go with the new physio model, but you're like, I'm trying to strengthen it, but it's not engaging. So for you, this one's a little bit harder because I would say this one correlates with getting that atlas to move side to side. And I know last time we had to be more angled forward. So even for you, I would say, and I don't know how comfortable you are trying this, what I do for something like this is two things. I go, whoa, I don't know why I had those balloons. That's super weird. Um, I go into a all fours position or quadruped,
Yeah.
and if you still feel, and so yeah, we can do several things. You can do retraction, or of course we could go into extension, which will be theoretically more suboccipital if you're hinging at C naught
Yeah.
C1. But you may need to change the position of your thoracic spine. So just try it with a neutral thoracic spine. And yeah, just see if that's any different in that position.
There's definitely more there. But I reckon right up in the suboccipital region rather than down further.
Yeah. So,
but it's funny in that, what was I thinking? And I'm still getting a lot of front.
So the reason you're getting this is because of that right atlas. They're going to correlate. Because you really should get maybe some symmetry. And this is not, these are just impairments that we're looking for. It doesn't mean you have to fix it day one, but when you're talking about like how is someone doing, how can I like get them, if you just think of a different model of exercise therapy. And so even for you, what I would strategize is like, all right, well, I want it to work mostly in the back and not the front. Sometimes we will get the front with this, but I would like for it centrally. But then the other thing I would think for you is like, hey, right or left. And then the third component, and that's what I just take this simple exercise and we just do it, is I want it to be able to get away from the suboccipitals. Because in reality, we're trying to get it to work more down here, right? This is, it's stretching the suboccipitals, but technically you're not working the suboccipitals. You are, no, let me rephrase that. We are working the suboccipitals, but it's more of an isometric for them because they're not really changing the length tension too much. Maybe a little bit as you go forward, but they're doing more capital extension versus protraction and retraction, right? Just think of up top. So the rectus, captus, posterior, minor, and major, the major ones that we're thinking about, like they're going to do capital extension, which is this. And so, yes, when you go back, it's kind of isometric for the muscle. But the big thing we ultimately want to achieve with this exercise is actually get the deep cervical extensors, which are going to be the multifidi and the like the splenius cervicis. Feel free to look up those. How well can I? Let me see if I can pull up my anatomy app here. Okay. Unfortunately, I don't have the ability to do this on my computer. It's just on my iPad. But
I can see that.
So this is I'm going to take you. This is the trap. So this is a posterior view. That's the trap, right? And so when we take away one of the layers, this is one of the muscles that we were trying to release earlier, and I think that's the splenius capitis. Yes, sorry. And so remember, that is one of the points that we were teaching to release. So if we're trying to release it, theoretically, we're trying to build up something else. Okay, so we're trying to release that one, and you can see that one's going up to the suboccipitals. The other one going to the suboccipitals. This is the semispinalis. Yep, semispinalis capitis. Let me take away a layer so you can see that one. Okay, so that's the semispinalis capitis. That's one of the ones that go right up to the inferior nuchal line, kind of right at the suboccipitals. You can see that's work. See how that runs all the way down. Sorry, it kind of has that
Oh,
blur.
yeah, I can see. Yeah.
Okay, because sometimes people are going to, some of the mistakes that will ultimately happen is they'll feel it in the suboccipitals and they'll feel it in the mid thoracic. And because you're trying to hit the mid cervical here, basically. So we were trying to release that. So we're not trying to work that one as much. And then here's the big boy view. Gosh, sorry. It's kind of, I don't know how to take off. Let me see if I can. All right. I took off the blur. Okay, that might be better. I like that blur, but so here are your suboccipitals, right? They're your suboccipitals.
Yeah.
These are the ones ultimately we're trying. I'm going to twist this for you. They're the ones you're ultimately trying to engage, right? Because they are the deep cervical extensors.
What is this program?
So this is called Complete Anatomy. It's a really solid program. Oh, and it's really good for patients. Just describe what we're trying to do. And they're like, oh yeah, I'm working. It just helps you see what we're trying to work. So just to give you an idea, when you ultimately do your retraction and you talk about getting mid-cervical extension, what is going to help extend those segments backwards? And that's it. So that's the location where we want to feel it. See the orange? So that's in the middle of the neck and maybe up into the CT junction area a little bit. And again, that is just me being that's how my practice works. I'm just very OCD of getting it. And it ultimately comes down to the better your lordosis is, the better these are going to work, right? So that's the big picture. What we're trying to achieve here is all of these are going to assist, and this is where the little bit of the art is, to assist in getting that C5, C6 to bend where we want it to. So we can take some of the most simple exercises, and I put several in there. We did that towel that I think you were saying that's a little bit of a, you can use it at C2 is what Mulligan did, or you can go down to C4, C5. Feel free to do all those. This is kind of more exercise therapy of how you can break it down. And so part of it is like if you start doing some of the manual work and then they say, oh, wow, look at here. Man, that's like working like crazy. It's like, boom, that's what manual therapy ought to do. Manual therapy doesn't fix people per se. It's not like canalith repositioning. That is pretty awesome that we can do that. But in the manual therapy world, they're trying to get away. You fix people, you release this, you release that. Now, I think it's great we have those. They're trying to get more scientific on the mechanisms. But my ultimate point is like when I put my hands on somebody, I'm trying to stimulate something that they can't stimulate right now. So for you, like maybe working that right side, like you can't get it to work on its own very well. And so I think that's why if someone intervene, they can like override that programming, if you want to think of it that way. And then ultimately the exercises should hopefully kick in, right? And with the principles of getting symmetry.
Yeah.
Okay. So, and there are lots of different variations of that, I don't know about New Zealand, but in the United States, there you have the iron neck. You ever heard of that? It's kind of the big bro guys wear it. I have some online consultations with people, and they have it. I don't even have it. But you put this thing on your head, and you like turn your head and stuff, and it's like a cable.
That slides from side to side.
You may be thinking this, which I was going to show you. Are you thinking?
Neck level. Yes, I've seen that. Is that any good?
Yeah, I brought it out to discuss. So I've had it for a little while. I use the same concepts that what we do here. I like it. It's nice because I'll take the resistance off. You can just simply do range of motion. You can do chin nods here. You can do capital extension. And then, of course, you have your resistance. And then you can do rotation. And I could do it. The thing I was going to tell you about it. I don't have the one that goes on the wall. I don't think for our clients we ultimately need that. But the thing that I always tell people is that you can use these same concepts that we are talking about of symmetry and stuff, and I just use it with this device too. So if someone's laying down and they're doing rotation, and if I turn my head to my left, I want my left side to work because that's shortening. And if I turn my head to the right, I want my right side. And hopefully more in the suboccipitals, because 50% of our rotation, what you're probably going to find, and if you ever got it, you may feel like your trap or your levator scapula on one side is doing it, right? So this, I use it as a test, and then, because I just don't put somebody in the corner and say, do 10 reps. Like, that's just not how our clinic works. So, so anyway, we like it. So there, you can just use these principles I'm teaching you with all the exercises to help get symmetry. I would say, based off of my my brain, they have like level 1 and level 2 exercises. The guy does a great job of breaking them down, to be honest. But they say anything prone is technically harder, and it should be, than laying flat. But we know with the clientele that we have like, we aren't supine, which we just proved a little bit with you. Like, the head need to be angled. So you may need to work the deep cervical flexors in a prone position, because the arms may be up, which is going to shorten the traps and take those guys out the equation and stuff. So anyway, don't always just go with being supine is the easy way. I gave a couple 6-week sample programs in the book, and that's kind of a typical. You start supine, you move to seated, you go prone. But nowadays I just do mostly, hey, how can we get it to work, right?
Yeah.
But yeah, next level. If you decide to get it, let me know. We should be able to get you like a code, get some percentage off. But yeah, that guy, I like it. I think he's done a really good job. Okay. So deep cervical flexors, deep cervical extensors are kind of just think of like, all right, these are the things I want to focus, and you're going to find that other areas are going to work, and then you just work backwards to try to ultimately get them to work as much as you can. And if you get that symmetry, what does that symmetry allow us to do? Oh, now we can hinge. And you base off of the anatomy model there. But and that doesn't come overnight, and they may be discharged before it's completely perfect, but that could be something that, again, you can teach. That's what my MO is where do you feel it? So that's what I'll teach them. Okay, let me show you one more thing, if that's okay, that is, because next week or the week after we'll get into the sensor motor, which you already kind of know a lot of, and I'll just tell you some things that we do, and I'll show you some of the tests and things that we use. That's some technology that's pretty cool. But here is something, and you can try it on yourself. So when we are talking about someone just naturally going into extension, we just sort of look up. But in order to really get it to hinge, sometimes we can force that C5, C6 to hinge. And how we do that is in a 3-step process. And you just do it with me. So instead of just going, oh, let me look up, you go like this. You go into protraction as far as you can. So you go into protraction. All right. And then you sort of lick ice cream. So imagine then you go in a little bit capital extension. So imagine licking ice cream. And now you try to get forehead or nose, or your nose vertical or perpendicular to the ceiling. and see if that feels different than if you naturally just look up.
Yes.
Did you go into protraction first?
Not that time, no. I was just feeling the normal thing where I just go back. But here, if you go forward, look, it definitely feels different. I've got more range, and I feel so tight through platysma on my left side.
Yeah, you got to get that right atlas better. Because we found that left side wants to work with deep cervical flexors and extensors, so that's why it's so tight, because it's overworking. Well, I would like to work on you if I could, but so that is it is. I can't claim I created that. I read about that in some research a long time ago, and the guy used some. Just some principles with that and looked at x-rays, and I was like, huh. So sometimes, depends on the person, sometimes we can get them to hinge and do a self-mobilization at C5, C6 because they're bending there with that like 3-step process. And so that may be where they may say, oh, look up. Ooh, it don't feel good. It gives me a headache. You may get them to do that. And they're like, oh, well, gosh, I don't get a headache or anything, but it feels tight back there. And that is another way for them to self-stimulate and try to get C5, C6 to hinge. So what I ultimately do is my goal from the get-go, our MO is to get that moving hinge too. How we do that is through some of the manual therapies. Some people go into the pillar or column that they need strengthening, they need retraining. And some people need more of the sensor-motor stuff, which we'll be discussing in 2 weeks. And then some people, we just kind of do a little bit of everything. But in the physio orthopedic world, about 15 years ago, they started trying to create these clinical prediction rules. So if you have 1, 2, 3 things you might fit into this category, kind of like how you all might looking at an anterior canal versus a posterior canal, something like that maybe. Like, what are some characteristics based off of what they're telling you that helps lead to that procedure? As far as I know, they don't really have those as much anymore because I think it's sort of just, I think they just kind of ran into like brick walls. Like, oh, okay, well, but what I'm getting to is that you're going to find sometimes like your older lady or gentleman who's in their 60s probably are going to need more of mobilizations and stuff to get that C5, C6 to work. Where if you have a very hypermobile concussion 16-year-old girl who plays soccer, they're going to need a lot more of that muscle retraining. Now, we can still do that with the elderly too, but you're going to just probably need to do some sensor motor training, some of that as well, where my older crowd, like, dude, does that really move the needle that much for them? I don't know. It could. It's just slower. And so anyway, part of this is just kind of giving you some different tools based off of the individual in front of you versus saying, I mean, I don't think your clinic works this way, but some people's clinic is like, oh, you have a concussion. Well, we'll do vestibular therapy. They go do this. We're going to do retraining. We're going to put them on one of these devices. They're going to do a traction, and then I'm going to manipulate their neck or something. Like, hopefully we can get a little bit more personalized. That's what we do. We try to, at least.
Yeah.
All right. So that seemed like a lot. That overwhelm you or give you some bigger picture thoughts?
It's really good, actually. It kind of makes me understand a lot more. And when I go and finish looking at the videos, it will give me a lot more information.
Good. Yeah. The videos just kind of break down some of the tests and then a few exercises like that.
And I need to read the book because I've got it there to read.
Oh.
My question that I ask, as I've been doing a lot of like putting my hands on and doing some more of the testing and stuff. When you're documenting about like how do you document? What do you say about the muscles when you're feeling them and one's like tighter on one side than the other, or do you write that there's tension or tightness? Like what?
Yeah, pretty much that. I would say that there's some findings of trigger points and or tension in the left SCM more than the right. Sometimes I'm a little bit more general in my notes. I'll be saying the left upper cervical. Like for you, I'll say you're probably more restricted on your right atlas, or the suboccipital muscles are tighter on the right versus the left. I kind of just do a little bit more general. I don't always name a muscle. Besides the SCM, it's easy to name that. Like you could name platysma if you want. That's a lot more detailed
I
than.
only know that enough from my facial clients. So.
Yeah. But I try to minimize my documentation. I'm really gotten bad at that. But I basically, when I write nowadays, so we don't do insurance here. So I write, so when I go to that note, the next time I'm like, oh yeah, Sarah was only feeling the platysma with this and that. And that's like my notes. Like, I'm saying like next visit, I'm going to see if I can get that symmetry, figure out why this is only firing on her. So, but for general sake, just say trigger findings of trigger points in the suboccipitals, in the SCM, the trap. That is all good and dandy. Now, you may need to potentially like sit down with your staff and you guys, because really for you, it's just kind of if in case one of your staff members needs to see them, like that you guys can have some consistency and some carryover. I think that's ultimately like the biggest picture. And you have we just have four of us. We have a fairly small staff, and and with some of our training within the clinic and stuff, we all have a little bit different styles and stuff, but for the most part, it's kind of hitting some similar areas. So, it doesn't have to be. I mean, maybe if you were doing like one or two specific areas, or if you were doing some dry needling or something, like you would need to really label the muscle and the depth. But I would write suboccipital releases, like treatment wise, suboccipital releases, SCM releases, epicranial aponeurosis release. Yeah, C5, C6 mobilizations. That's about what I do.
Yeah, no, it's just that muscle, like, no, that makes sense. So kind of what I've been writing, I was like, oh, what do you write?
You can always like pull up anatomy app and get real specific if you're on a specific muscle, but quite frankly, the big picture, if you say you're like on the rectus capitis posterior minor, like you're technically on the trap first, and then you're on the splenius capitis. So it's that third deeper layer. So now if you were going to needle it and say, hey, I'm going to go through those other muscles till I hit the bone, then I know I'm going through the rectus capitis posterior minor. But otherwise I'm a little bit more generic. Quite frankly, I would be like, if I say, hey, this is the exercise I'm doing, I'm going to be writing next to it where they felt it. I know that's not a normal like note, but that's just how I do. So when I go in next time, I'm like, this is what I want to accomplish.
You get that, right? Like I've got like, you get your own little things like sway plus, sway plus plus, sway plus plus plus.
Oh yeah. Yeah, we do definitely, our field it's cool if we can get some technology and objective measures. And I'll show you some stuff that we use for the neck, either next time or last visit or last time. But
I'm not here next time, though.
Say what?
I'm not here next week.
Oh, all right. So
I've got another
you know what we may? It's technically for the last week, and next week it may just be me and you. And if no one shows up, I'll just say some things to to talk about it. But next week's technically the vestibular component of how we integrate, and you know all that stuff. So we'll go over some stuff in 2 weeks and sensor and motor stuff you'll really like, hopefully.
That will be good. It's good because we do sensory motor, and it's like I feel like after doing this, it's like, oh yeah, we do assessment, vestibular, sensory motor, and miss out all the manual stuff.
Oh no, and that's fine. I would love to see if you feel like you like the cocktail of putting it all together. If you can get it to flow, like we talked about last time, that'll be. So you just slowly integrate a few things. That's why I didn't give you like 5,000 exercises. Because then it's like, how is that going to flow with you guys? Like if I say, here's 25 different ways to get it. We just teach you some of the principles. And then, because those exercises work. There's nothing wrong with them. The new age people are like, we got to go heavier and this. And in certain muscle groups, but not always with the neck. It was not meant to do that. So, all right. Well, we'll catch up in 2 weeks. And feel free to shoot me any questions if you have them. But look forward to it.
I will do. Thank you. See you in 2 weeks.
Okay.